All right, so differences in sex development are congenital conditions in which there is discrepancy among the chromosomal, gonadal, and phenotypic sex of the individual. So today we'll talk a little bit about the history, or fairly recent history, of care for these conditions and the International Consensus Statement. We'll talk about nomenclature. We'll review Sex Development 101. And then we'll talk about evaluation and management of individuals with these conditions. And then I'll tell you a little bit about our sex development program at Lurie Children's. So as I talk today, I'm going to kind of weave through a specific case that I think will illustrate a lot of the points that I have to make today. So we're going to talk today first about baby G. And this baby was going to be the first baby for these parents. And so they were having their first child, and they had one of these gender reveal parties. Is everybody familiar with this concept? Yes. So they go and they get their ultrasound, and maybe the parents know, or maybe they have the ultrasonographer put the information in an envelope, and they have this big party with all their family and friends, and they find out whether they're having a baby girl or a baby boy. And oftentimes there's a cake involved. So I found this picture that I thought was very cute. So these parties are they are wonderful celebrations during pregnancy, but I will tell you, as a pediatric endocrinologist, they give me some palpitations, and you'll see why. So this family was told they were having a boy. So when the baby was born, the baby had atypical genitalia, and it actually wasn't completely clear based on the genitalia whether this baby was a baby girl or a baby boy. So the baby had what we refer to as a clitorophallic structure. So there was a structure that was larger than a typical clitoris, but smaller than a typical penis. It was about 1 centimeter. You couldn't feel any gonads, so that's the generic term we use for the structure that becomes ovaries or testicles, but you couldn't feel any. The baby had perineal hypospadias, so the opening, the urethral opening that urine comes out of, wasn't at the tip of this clitorophallic structure. It was somewhere along it, kind of near the base, like the perineum there. And then the baby had what we call a bifid scrotum. So typically the scrotum is one sac, but instead it was sort of like this, where it's two. So it's sort of two separate sacs. So, most families have this really ideal picture of what it's going to be like when their baby is born, and they're going to have this baby come out, and they're going to say, it's a boy, and everything's going to be perfect. And we know that often, there can be some bumps along the road, and so that's what happened for this family. But they had never even heard of conditions like this. They didn't even know this could happen. So this was very difficult for them. All right, so before I go any further with this patient, we're going to back up and talk about the history of care for these conditions. So we're going to start by talking in the 1950s and 60s about the model that was developed at that time. And there is a psychologist named John Money at Johns Hopkins who developed what was called the model of optimal care. And basically, their belief was that in babies that had atypical genitalia, that was not completely typical of a male, that you should do sex reassignment surgery and raise the baby, and not tell the child, but raise the baby, for example, as a girl, because the environment could determine gender identity, and that was more powerful than any other innate qualities in the baby. So the hallmark case was what's called the John and Joan case. And so this individual there was a set of twin boys born in 1965, and at 8 months old, one of the little boys had a circumcision done with significant complications, such that there was really no penile tissue left. And so they weren't really sure what to do, and the family was referred to see John Money. And he recommended further sex reassignment surgery to make the baby appear completely typically female. and then to reassign the baby as a girl. So John became Joan, and the baby was raised as a girl. And they would have follow-up appointments at Hopkins where they tried to reinforce female gender identity. And over the years, they started to encourage vaginal reconstructive surgery. And in 1972, John Money published a paper that this John and Joan case was a success, and gave the advice an intersexed baby with female-appearing genitals should always be assigned female. And in the case of a genetic male baby born with no penis at all or with major hypoplasia of the penis, the baby should be assigned as a girl. And so this was the prevailing thought at this time. But it was a little more complicated than that, because Joan was not actually very happy. Joan was really struggling. So she wanted to play with her brother and his friends and do all of the typical sort of rough and tumble male play. She didn't want to wear dresses. She would rip them off. She wanted to wear boys' clothes. She wanted to urinate standing up. She was having a lot of behavioral issues that went along with all of this distress. So in 1979, actually, Joan, at age 14, was seeing a local therapist who had spoken with the parents, and they decided they really had to tell her. So they disclosed the whole history, and life made a lot more sense. And Joan wanted to go back to living as a boy, and so transitioned back to living as a male. And at that point, John Money stopped publishing about this case. And this is all the basis of the book, As Nature Made Him, by John Colapinto. It's a really powerful book if you're interested in learning more of this story.
I have a question. Is the John is chromosome in this?
46XY, typical of a male. Mm-hmm. And when he was born, he looked completely typical of a boy. It was only because he'd had this complications from a circumcision that there had been really any abnormality in the genitalia at all. All right, so if our baby had been born like in the 50s to 70s, the baby would have been given what was called an intersex diagnosis and would have had sex reassignment surgery to appear female. We would have recommended to rear the child as a girl, name her Rose, like something really girly, and reinforce female gender play, gender identity, and don't tell anyone, especially Rose. And this was all done, I want to make sure I'm clear, this was all done with the best of intentions. This was thought that this was the best thing for these children. But in the 1990s, the activism movement in this field began. And in 1993, an individual named Cheryl Chase, who was intersex, founded the Intersex Society of North America. And individuals who had been cared for in the manner that I just described came together and formed this group, otherwise known as ISNA. And they demonstrated, and they had, I think, a little bit of a sense of humor about some of it, but hermaphrodites with attitude. But they were upset about the care that they had received, and for different reasons. So some may have just been unhappy with the sex assignment. Some may have been unhappy with the surgeries that were done. Many of the surgeries that were done in the past, and these are not techniques that are used now, but many of the techniques that were used were really they put more emphasis on cosmesis, so how somebody looked, and they didn't always think about function. So for example, they might have cut nerves to the clitoris, and it might have been that somebody was not able to have the same kind of sexual satisfaction that they would have otherwise. There were also, and then there were other issues with the fact that many of these, the history was kept secret. So a lot of individuals didn't know anything about their history, their surgeries, any of this until they were adults, and they requested their medical records, and then they read about it. So for many reasons, there were many individuals that were not very happy. And in 1997, Milton Diamond, who's a psychologist and had worked with the individual in the John and Joan case, published on this and on the whole story of John and Joan and said, "We suggest this means referring the parents and child to appropriate and periodic long-term counseling rather than immediate surgery and sex reassignment, just because that seems a simpler, immediate solution to a complicated problem. Social difficulties may reveal themselves as puberty is experienced. However, there is no evidence that with proper counseling and surgical repair when best indicated, an adjustment will not be managed, as teenagers manage other severe handicaps. Future reports will determine if we are correct." And so in 1998, the American Academy of Pediatrics made recommendations. And they said there should be a general moratorium on sex assignment cosmetic surgery when it is done without the consent of the patient, that this moratorium should not be lifted unless and until complete comprehensive retrospective studies are done, and it is found that outcomes of past interventions have been positive. And efforts should be made to undo the effects of past physician deception and secrecy. And so this brings us to 2006, when the International Consensus Statement was published. So about 50 individuals from around the world, endocrinologists, psychologists, surgeons, ethicists, stakeholders, met to acknowledge and discuss the controversial issues in intersex management. And they acknowledged that we often don't really know how to best raise a child with ambiguous genitalia. They made recommendations about nomenclature and definitions, about evaluation and management, and they expressed that it was very important for these children to be cared for by a multidisciplinary team. So first, we're going to talk a little bit about the nomenclature. So you've already heard me use a number of different terms, and I'm going to kind of explain them a little bit more. So this table shows on the left what the previous nomenclature was. So terms like intersex was kind of the general term to describe an individual like this. There were words used like male pseudo-hermaphrodite, hermaphrodite, a number of words like that. And many of them were thought to be somewhat insensitive. And in addition, there had been progress in molecular genetics and our understanding of some of these conditions. And so in the consensus statement, they proposed new terms. And instead of saying intersex, they used disorder of sex development. And then instead of male pseudo-hermaphrodite, and that term always used to confuse me in medical school, I couldn't keep straight what that meant, and now it made so much more sense after they changed it. To 46XY DSD. So they made it based on chromosomes. And then a true hermaphrodite became ovotesticular DSD. And so basically that means that an individual has both ovarian and testicular tissue in the same person. So, is this new nomenclature universally accepted? No. This is an issue in this field. The words that we use are really important, and it's what is preferred and accepted by one individual may not be by another, and this could be a very sensitive topic for somebody. So there have been a number of studies that have started to come out on preferred nomenclature. And I don't think we have an answer yet, but I will tell you that one of my colleagues, Emily Johnson, is a urologist here at Lurie, and she has been doing a study called Attitudes Toward Disorders of Sex Development Nomenclature Amongst Affected Individuals. And for the first portion of this study, we've partnered with a support group called the Androgen Insensitivity DSD Support Group to survey their members about the current nomenclature. And we could talk about that all day, but I will tell you overall that so far disorder in any term is not popular. The term intersex is actually still preferred by some individuals, and that actually nomenclature may affect people's decisions in seeking health care. So there are individuals who say, I will not go to a clinic that has disorder in the name. So these are things that we really have to think about as we try to provide good comprehensive care. So what words should we use? And we really don't know yet. We don't have a good answer. I think what we are learning is that because each individual may prefer different terminology, that ideally we ask individuals what they prefer. That doesn't necessarily help us name a clinic exactly, but it does help us when we think about our individual interactions. So now I'm going to kind of back up a little bit to talk, now that you kind of know a little bit of the background here, we'll talk a little bit more about actual sex development. So there are 3 main steps in sex development. First is establishment of chromosomal sex. So when the baby is being formed, the egg and the sperm come together, and the mom gives an X chromosome, and usually the dad gives an either X or a Y chromosome. Once that happens, then the information on those chromosomes gives information to tissue called gonadal tissue, and tells it whether to become an ovary or a testis. And then the hormones produced by ovaries and testes give information to the rest of the body about how to develop, so what it should look like, so the phenotypic sex, and that's on the inside and the outside. And so if we look in a little bit more detail, when I talked about there's tissue that becomes the gonad, so initially that tissue can become either an ovary or a testis. It's exactly the same in every baby that's forming in the first 5 to 6 weeks of gestation. And initially it's in this area called the urogenital ridge, which then develops into a bipotential gonad. So that means it can become either an ovary or a testis. And how that tissue develops is dependent on a whole lot of proper function of transcription factors. And I've listed a few of them here, but there are many more. There are probably at least 100 genes that we know of that can have some impact in this process. But once that bipotential gonad forms either into an ovary or a testis, then the ovary has granulosa cells, which make estrogen and cause follicle development. The testis has Sertoli cells, which make a hormone called anti-Müllerian hormone, and that causes regression of Müllerian structures, and we'll see them again in a minute, but those are structures that become what you typically think of as sort of female internal structures, like the uterus and vagina, upper portion of the vagina. But in males, they make something called the anti-Müllerian hormone to kind of make all of those structures regress or go away. And then they also have Leydig cells, which make testosterone and dihydrotestosterone, and that causes stabilization of typical male internal genitalia and then further development on the outside. So if we look a little differently here, here's the picture where you look at this indifferent stage. So this is what's inside of a baby prior to about 6 weeks of gestation. And so you have this gonad, which is bipotential still, and then you have all of these Müllerian ducts, which can become which then would become the fallopian tubes, the uterus, and the upper portion of the vagina. And then you have Wolffian ducts, which would become the epididymis, vas deferens, and seminal vesicles. So as you can see, really, it's if there's any little difference along the way, that causes some of the conditions that we see, because everybody starts out exactly the same. And externally, the same is true. So by about 6 weeks of gestation, this is what you would see in a baby's genitalia if you're sort of looking straight on between their legs. So you see up here at the top, my mouse here, this genital tubercle. This becomes the glans clitoris and the glans penis. The urogenital slit here becomes the opening to the vagina, and it zips up here in the male. Then you have what's called urethral folds here and the internal part, and that becomes the labia minora in a typical female, and it becomes the shaft of the penis here in a male. And then you have labioscrotal swellings, which become the labia majora in a female and the scrotum in a male. And then really the clitoris and the penis come from that same structure, and it's just with the effect of testosterone that you see growth of the penis and that zipping up process that happens. but everybody starts out exactly the same. So I said, we have these 3 steps. You have establishment of chromosomal sex, gonadal sex, and phenotypic sex. And the way we think about all of the differences in sex development that you can have is by sort of the abnormalities that could happen in each step. So if there's an abnormality in establishment of chromosomal sex, then you get what we call a sex chromosome DSD. And so these are situations in which the chromosomes didn't form properly. So instead of having 46XX that we typically see in a female or 46XY that we typically see in a male, you might have an individual who is 45X, and that's what we usually refer to as Turner syndrome. Somebody might have an extra, so they might have 47XXY. That's what we think of as Klinefelter syndrome. They could have mosaicism, so some of their cells might have 45X and some might have 46XY, so that's called mixed gonadal dysgenesis. And then if the chromosomes form properly, then you can have, then you kind of go on to the next step, which is that establishment of gonadal sex. And I showed you all those different transcription factors that have to work exactly right for those gonads to form properly. And if they don't, then you get what we call disorders of gonadal development. So it might be that the gonads don't develop really at all, and those are situations that we call complete gonadal dysgenesis. You might have a situation in which they form partly, so partial gonadal dysgenesis. There are ones like ovotesticular DSD, where some of the gonadal tissue is ovarian and some of it is testicular in the same individual. Obviously, there are many here. I'm kind of hitting the highlights. But if the gonad forms properly, then you can also have disorders of androgen synthesis or action. So androgens are the hormones that are like testosterone. And you can either have too much of them or too little of them, or maybe they don't work properly. So in a 46XY DSD, this is somebody who was starting along the path to become sort of a typical male. But if they don't make enough of a testosterone-like hormone, or if it can't work, then they may not have typical male development. So one of these common situations would be in a condition called androgen insensitivity syndrome. And so that can be either complete or partial, but I think complete is one of the most helpful ones to think about. So in that situation, an individual is 46XY. Their gonads develop into testicles. The testicles make testosterone, but the androgen receptor, so where that testosterone is supposed to bind, the receptor doesn't work properly, and so their body never sees any effects of testosterone. So externally, that person at birth looks completely female. But internally, they actually have testicles, and they have some of the other internal male structures. But they don't have a uterus. They don't have the upper portion of the vagina. But on the outside, they look completely female. And they may go through childhood and adolescence and not know that they have this. It might not be until puberty doesn't happen quite as it might be expected to, or they don't get their period, that you might go and realize there's something that's not quite right and figure this out. There can also be another really common condition is one called congenital adrenal hyperplasia. So that's in an individual, the most common thing that we see would be in an individual who's 46XX. So they have chromosomes typical of a girl, and they have ovaries, but their adrenal gland actually overproduces testosterone. And so it causes changes in the external genitalia that can make them look sort of ambiguous, or maybe even almost completely male appearing. And that's just because of the effects of testosterone on the external genitalia. So these conditions vary widely, but that's sort of the overview of some of the common things that we might see. We'll talk a little bit about our evaluation of in these situations. So when do we look for this? Well, clearly in the situations when we see a baby born where there's what we call sort of atypical or genital ambiguity. But sometimes there are situations that maybe aren't quite so obvious, but we still need to know to look. So maybe a baby has a very large clitoris, what we might call clitoromegaly, or maybe a boy, an infant that's born, somebody says, oh, that's a boy, but then they look and they say, well, there's perineal hypospadias, like the opening to the urethra is down at the base of that penis, and you know what, actually we can't feel one of the testicles. Those are situations actually in which an evaluation is really warranted. Some of these conditions are inherited, so there may be a family history, like there might be an aunt with complete androgen insensitivity syndrome. Nowadays, we're finding more situations in which we would say there's genital and karyotype discordance. So when the mom is pregnant, she has some kind of amnio or something where they actually find out the chromosomes for the baby, and then the baby's born, and they say, well, that doesn't quite match. Like I was expecting a boy, and that baby doesn't look like a boy. Things like that. Then there are situations that come up later, like I had mentioned, where there might be delayed or incomplete puberty, or a girl might start having signs of a lot of testosterone exposure. Maybe a girl doesn't start her period, or maybe there's a boy that starts having what looks like blood in his urine, but it could actually be menstruation if there's actually a uterus that's still present. So these evaluations are really challenging, and one of the things I have learned is that the more we can set appropriate expectations, the better we can do. So this is really stressful for parents. They had this image of how everything was going to go, and especially when you have an infant with one of these conditions, it doesn't go that way. It's really hard. And what's even harder is that we can't do this evaluation quickly most of the time. So it's time consuming, and there's a lot of good reasons for that, but it's really frustrating for families. So we'll talk a little bit about the parts of the evaluation, but it's the timing of the testing that we do is really important, and if you do it too soon, sometimes you would come to the wrong decision. So this clinical evaluation involves talking about family and prenatal history. Sometimes you do actually find that somebody says, oh, yeah, actually there is somebody in our family who, had this or that. The physical examination actually tells us a lot in terms of it can really guide our thinking when you've seen a lot of babies like this. But what I also try to do is to really show parents what they're seeing. So a lot of people have never seen a baby's genitalia before. They don't even really know what's normal and what's not. And it can be kind of frightening. And so just showing parents what we're seeing and how the terminology we might use for some of the structures they're seeing can be very helpful. One of the things we can actually do on the first day that a baby is born in this type of situation that can be helpful is to get a pelvic ultrasound. That can tell us if there are any of those Müllerian structures, like a uterus. That can really guide some of our thinking. For example, if there's a uterus present, I know that there was not sufficient anti-Müllerian hormone present. So that tells me either there wasn't a normal testicle or there was an ovary present. It really can start telling me what path I'm thinking about. It doesn't actually really help us very much most of the time in terms of telling whether there are ovaries or testicles present and what that structure is. Babies' gonads are just really tiny, and it's really hard to see them, and sometimes we just don't know. We just can't tell. And then MRI is not really usually much better. So in certain situations we might think about it, but really pelvic ultrasound, we're mostly using it to tell us, is there a uterus? Then there's the endocrine lab evaluation, so really measuring all of these hormone levels. And you will always see a picture like this if you have an endocrinologist giving you a talk, because you have to think through these pathways. But what we have to do is to evaluate sort of each part of the pathway that makes these hormones. So we have to think about whether the pituitary gland is making hormones properly. So those are hormones like LH and FSH that are gonadotropins that stimulate the gonads. And then we have to figure out whether the testicles are making testosterone, estrogen. We have to measure hormone levels in the adrenal gland. And when I said that the timing is tricky, this is really where it comes into play. So baby physiology changes over the first couple weeks of life. So if you measure these hormones on day 1 of life, it is not very helpful. Like the adrenal hormones, you really should start measuring on about day 3. The LH, FSH, testosterone, estradiol, you can't even hope to get any useful information until about 7 days of life, and often it's more like 2 or 3 weeks. And that's because babies have what's called this mini puberty of infancy. So when they're born, they start to have this whole system ramp up, and their pituitary gland starts to make LH and FSH, and it tells the testicles or ovaries to make testosterone or estradiol. But that doesn't happen. That whole system doesn't get ramped up until at least a week, and really not until 2 most of the time. And so if we measure these hormones on day 2, it doesn't really tell me anything. So I have to spend a lot of time trying to explain that to parents who are anxious for some of this information, be able to say, I would like to, but it really wouldn't be helpful. Then there can be a lot of molecular genetics that can be helpful, and I'm going to talk about this in a little bit more detail in a few minutes, but karyotype, so just figuring out what those chromosomes are. And then there are some more complicated things that we have now called microarray and next generation sequencing that are very helpful. But even a karyotype, it takes us 48 hours to get a preliminary result. And that's pretty accurate if you're at a good place and your genetics lab is really helpful, like ours is at Lurie. But to get a final report often takes a week or a week and a half. All right, so if we go back to our baby, I said, ultrasound is one of the things you can do right away, and so we did. And there was a structure that was suggestive of a uterus. On the right, they saw a gonad, and they thought it was most like a testicle. They can see sort of what's called the mediastinum testis in there, and they thought it was probably a testicle on the right. And then on the left, they couldn't really tell. They really didn't see any definitive gonad. But then on day 3 of life, we had said originally we couldn't palpate any gonadal tissue on an exam, but then on day 3, there was actually a gonad that was palpable in the right inguinal canal. All right, so it turned out that this baby's karyotype was 46XY, so that's typical of a male. And on day 3, when we measure all those, the adrenal hormone levels, those were all normal. And then on day 9, we measure some of the rest of the hormones. And so one of the things that I think actually is helpful is to see that on day 3, this baby's testosterone level was 44, but on day 9, it was 314. 314 is normal for an infant male, but if you had based your decision on the labs from day 3, you would think that that baby wasn't making a normal amount of testosterone for a boy. So it's really, this timing is really important. So so what we see here is actually the gonadotropins, the LH and FSH, are normal for the mini puberty of infancy. The testosterone is typical for a baby boy. The estradiol is relatively low, which is typical for a baby boy. We look at the ratio of testosterone to something called dihydrotestosterone that tells us about this other converted form of it that's very potent. That's normal. And then we look at the anti-Mullerian hormone level, which is down here on the bottom. And that level is actually it's high for a girl, but it's actually low for a boy. So it's kind of somewhere in between. So what do we know about this baby? So we know that this baby has what we call a 46XY DSD. So it kind of goes into that middle column that I showed you earlier. We know that the baby has a descended gonad on the right side. And when a gonad comes down, when it descends, we know that it's at least partly testicular because there are certain hormones in the testicle that are present in a gonad that descends. But you could still have an ovotesticle that could come down like that. So we don't know for sure, or it may not be completely normal testicular tissue, but we know it's at least partially testicular tissue. We know that there's a uterus present. We know that a lot of the hormone production was, the gonadotropins were normal, the testosterone was typical for a baby boy, that AMH level was kind of in between, and that the adrenal function was normal. So I just said we're sort of in this middle column. And so then we have to think through all these different conditions and what this could be. So the baby at least has one gonad that is descended, and there's a lot of testosterone being produced. So we know this baby at least has some gonadal function. This baby does not have complete gonadal dysgenesis. Gonadal regression is a condition where the gonads completely regress or go away. That's not this. And because the hormone tests were, for the most part, normal, this is not an androgen biosynthesis defect. It's not a defect in androgen action because those individuals do not have a uterus. And then I will skip through a few of these other ones, but basically we're left with initially thinking this is either partial gonadal dysgenesis or an ovotesticular DSD. Now sometimes you could miss low levels of mosaicism, so sometimes we keep in the back of our mind that it could still be a condition like 45X, 46XY. All right, so why did this happen? So one of the ways we could try to figure that out is by some of these more advanced molecular genetic techniques. So we can do something called microarray. This identifies submicroscopic chromosomal or anatomy abnormalities, so like small deletions and additions, so extra chromosome material on a chromosome or some that is missing. It doesn't identify really small insertions, like one little tiny thing that goes in there or something that's missing. But when you do microarray in individuals with DSD in whom you don't know the cause, in about 13% of the cases, you will find an abnormality in that microarray that tells you why this happened. You can also do single gene sequencing. So for example, that means like in an individual that has complete androgen insensitivity, and that's what if that's what we thought they had, you could actually sequence the actual androgen receptor gene. So you're choosing one gene and you're sequencing that gene, just looking for a mutation in that gene. And that's all we used to have. And it is helpful if you have a really good idea of what you're looking for. But a lot of the times you don't. And so then you kind of send this test that takes 2 months and is pretty expensive, and they're like, nope, that one's normal. And you're sort of back to square one. All of these tests are expensive, but that one can be particularly frustrating because then sometimes you move on to the next single gene and you get another no. And so we're really moving away from that in most cases to some of these other techniques. And next generation sequencing is one of those. So in this here, you're really sequencing big areas. So maybe the whole coding region, so all the exomes, or like a targeted gene panel where you say, well, we know 150 different genes that could cause DSDs, so we're going to sequence all of those at the same time. And these techniques can be really helpful. So using whole exome sequencing in cases of undiagnosed DSD, so far it looks like you can find causes in about 40% of them. The things you find in microarray and next generation sequencing are sometimes different. So sometimes it's not an either or, sometimes it's a do one and then do the other. This particular family actually chose not to pursue any of that, so I don't have an answer for you on that, but it is very helpful. So what do we do for management? So one of the major tenets that came out of all of that historical experience in the international consensus statement was to try to avoid irreversible surgeries until the individual can participate fully in the decision. So there are some surgeries that are still done, and there's a lot of thought that goes into what surgery should be done when, but we really need to think about it a lot more than we used to. So initially, for an infant like we talked about here, sex assignment is one of the first things we have to address. And there may be someday that people are able to be comfortable saying, not assigning sex as a boy or a girl, but right now that's just really not the society that we live in. And for parents, they really need to make a choice here. So it's really challenging. It often depends on the diagnosis, on the guidance and advice we might give to parents. What we really try to do, though, is to work with them, to explain what we know and what we don't know, and to try to help them make the best decision for their baby and their family. And that may not be the same thing for every family. But I'll give you a couple of examples of common situations. So in that case that I talked about with congenital adrenal hyperplasia, where a baby is 46XX and they make a lot of extra testosterone from the adrenal gland, and so the external genitalia may be virilized, we know that 95% of those individuals grow up to identify as girls. So we would typically recommend that a family raise that child as a girl. Now, 95% is not the same as the general population, so there is actually a higher chance that that child will have gender dysphoria and identify as male, but 95% of the time we think that they will identify as female. In cases of 5-alpha reductase deficiency, it's even more complicated. So did anybody read Middlesex? Okay. So the book Middlesex is about an individual with 5-alpha reductase deficiency, and so this is a condition in which the chromosomes are 46XY, and somebody has testicles and they make testosterone, but they can't convert testosterone to this more potent form, dihydrotestosterone. So the external genitalia can look anywhere from typically female to typically male, depending on how much of that hormone was made. And so in individuals with this condition, we know that, and these are all small studies, okay? These are not super common conditions, so we're often trying to base the recommendations on not a lot of information. But the information we have is that those raised as boys typically continue to live as boys and identify as boys. In those raised as girls in this condition, about 50% of them at puberty will have gender dysphoria and desire to transition to living as a male. So typically, if we would know that this was the condition at birth, we might recommend that somebody raise the child as a boy. But I have seen girls who are adolescents and are perfectly happy as girls who have this condition, so it's very hard to know. And then there are cases of mixed gonadal dysgenesis where we see more identifying as male than female, but we really don't know. So this is the kind of information that we have to then give to parents and to help them parse through. But typically, we would try to help somebody make a decision within the first week or two of life. Yes. So we have this empathetic discussion with the family. We typically recommend that they delay naming and sex assignment until we have a little bit of information. But sometimes they may, and I have found this a few more times recently, they may just feel more comfortable choosing a gender-neutral name so that whether they choose to raise this baby as a boy or a girl, they've kind of had a name, and it sort of helps them to bond with the baby. And so I've actually come to think that that can be very helpful for some families. They typically need endocrine and surgical consultations. We have to gather all this information. Mental health support and consultation is really very, very helpful. It's really essential, I think. We often need some information or some consultation from a genetic counselor, a geneticist. A lot of times there isn't an actual medical emergency at birth, except for in cases of adrenal insufficiency. And in that case, it is important that we start replacing certain adrenal hormones right away. So in this baby, we advised a delay in naming and birth announcement. Sometimes we can tell families that they might, because everybody says, oh, you had your baby, did you have a boy or a girl? So what we often recommend would be, some families are comfortable telling everybody they're not sure yet. But many aren't, and so in those situations, they might be able to say, you know what, the baby has some medical problems, so we'll tell you all about the baby as soon as we're a little more comfortable, but we're gonna just take some time by ourselves for now, or something like that, just put everybody off for a little bit. So we really try to educate the family about all of what I'm telling you today about sex development and gender development, and really support the family's choice for the sex of rearing. During childhood, we're following gender development, providing age-appropriate explanations to the child. They may continue to need adrenal hormones if that's the issue. There are certain surgical interventions that are considered. There are some that you need to do just to explore, to sort of define some of the anatomy. Sometimes you need to do a biopsy of the gonads. What's tricky is that in a lot of these 46XY conditions, there's actually an increased risk of tumor and cancer development in abnormal gonads. And so that has been a reason that many of these gonads have been removed in the past. It's a very controversial issue in terms of what the risk is and whether you should, when and if you should remove these gonads, but that is an issue that we face. And then some of the infants, particularly like being raised as males, may have a hypospadias repair. In adolescence, again, you have to assess that pubertal development. You may have to give estrogen or testosterone for that individual to have physical development like puberty. You have to follow the gender development, provide more complex descriptions and discussions of the condition, and discuss sexual function and fertility potential, and then consider whether other further surgical interventions are appropriate. So if we go back to our baby, this baby actually had surgery a little bit earlier than would have usually happened because there was another emergency that came up for this baby. But the baby had a vaginoscopy, so they looked in and they saw a normal appearing vagina and cervix. There was a uterus present. It was actually pulled through the right inguinal ring, so it was like coming down this way. And on the right, there was this gonad that was kind of atypical. It had a fallopian tube associated with it and a vas deferens, so what typical internal male and female structures. They completely brought it down. It was sort of in the middle. And then on the left, they saw a small yellowish gonad that looked abnormal. There was also a fallopian tube on that side, and they did a biopsy. So what they found on the right was that structure that you could see descended in the scrotum later. That was a dysgenetic testis. So it's a testis that just didn't form quite properly, but it does have many features of a testicle. And then on the left is what we call a streak gonad, which is a gonad that never really formed. There's just a little bit of tissue there. This baby did have, eventually that left streak gonad was actually removed due to the increased risk of tumor formation in that kind of tissue. The uterus was left intact. This is consistent with a diagnosis of partial gonadal dysgenesis. And this family chose to raise this baby as a boy, but the surgeons left the uterus there because we certainly know there's a higher rate of gender dysphoria in individuals with DSD. And if this individual later grew up and identified as a female, we really wouldn't have wanted to remove a structure that's otherwise not harmful. So having a uterus there doesn't hurt this child. It really never has to be removed. There might be a few situations in which you may want to, but and it might be that this individual, if he identifies as a male, would like it to be removed later, but that's a decision he can make. So I talked about the things we know, but there's so much we don't here. So why did this occur? We don't know. All that genetic testing might help us, it might not. How is a dysgenetic testis making a normal amount of testosterone? I don't know, but it is. Will this baby identify as male or female? I don't know. What if the family demanded that we take that uterus out right now? Because some families do. This particular family did not, but that's really tough. And people would have 15 years ago. They would have just removed the uterus, but we're trying to be a little bit more thoughtful about that, and so that would probably be something that we would talk about with the ethicist that's on our team. What surgeries can you think about doing in adolescence? So we talked about the fact that individuals had wished they didn't, like adults had said, you shouldn't have done genitoplasty, or you shouldn't have done all these other surgeries. Well, at some point though, somebody may want some surgeries or some things done. And when is somebody old enough to make that decision? And I don't think we know the right answer. I mean, there are 13-year-olds who come saying that they want some of these surgeries done. Do they really know? They might, but they might not. What about 16, 18? I mean, it's really hard to say, and it's probably very specific for the individual. Is there any potential for fertility or fertility preservation in these individuals? That's a big question mark in most of these conditions. All right, so I'm almost done. I know I've tried to fit in a lot to explain all of this to you, but I'll tell you, we, in the Gender and Sex Development Program at Lurie, we opened a formal multidisciplinary program in August of 2013. We've seen over 150 patients in the program, which is actually quite a lot for these types of conditions. Our team is composed of individuals from urology, pediatric surgery, psychology, endocrinology, genetic counseling, ethics. We have a nurse from endocrinology that works with us, and we have a coordinator. And we do inpatient team consultations for babies, infants that are born. And then we have a multidisciplinary outpatient clinic that meets twice a month. So we meet beforehand to talk about the patients that are coming. All patients meet with somebody from each of those disciplines. We hold quarterly conferences where we really pull in a lot more people from Northwestern and Lurie, not just the people from our multidisciplinary program. And then we have an active research program. So we're studying a lot of the questions about fertility preservation in DSD and about nomenclature. And then we're part of what's called the DSD-TRN network. So it's a national registry and a group of 10 institutions who are working together to study this population. All right, so that's everything I can teach you in an hour about DSD.